So we are in the home stretch. We have two more talks. So we are going to next do medical ethics, and then we will conclude with breast cancer with Dr. Nanette Robinson. So my name, of course, is Ananth Shenoy. I want to acknowledge that these slides are borrowed very liberally from the amazing Dr. Joyce Whip, who was our course chair with Dr. Powell for many years. And this is a talk on, of course, medical ethics. And as far as its weight in the boards, there's not a specific content area for medical ethics. However, it touches on a lot of the other content areas we've been covering throughout this course. And in particular, you're going to want to watch out. I want to say watch out. You will want to look for it, particularly when it comes to geriatrics cases, because that's often that and end of life where we're kind of more likely to see these questions come up on the boards. And of course, they are also useful to us in our day-to-day practice. Now, my disclosures, I am not a professional ethicist. That is my primary disclosure today. So when thinking about the ethics of medical care, essentially really all medical care, this is the point that Dr. With makes very effectively, involves ethics. It's just most of the time they go smoothly, and we're kind of operating on a mode where kind of what has been ingrained into us is just acting. And so when you really make a point of calling out, like what are the principles that guide us and what are kind of the primary topics, we're going to be discussing today medical indications and then the very important patient preferences and how that balances with quality of life, and then thinking about contextual features that can influence a case, including things like socioeconomics as well as legal aspects and then kind of other administrative and logistical challenges. So we're going to start with a case. Again, we're going to have a bunch of cases. So our first case is a 56-year-old who has recently been diagnosed with metastatic renal cell carcinoma. The diagnosis was made in pre-op evaluation for a humerus fracture sustained after a fall, and pulmonary nodules were noted on chest X-ray, so stage 4 metastatic disease. The patient has had extensive consultation with oncology, who recommended immunotherapy for basically extending their life. The patient, though, has declined and wants only palliative care. He has two children, ages 14 and 17. So, question one for this first case. So, newly diagnosed renal cell carcinoma with metastatic disease. The patient declines treatment. What should you do? A, have the patient declared incompetent. B, refer the patient back to oncology for another discussion. C, offer palliative care, and D, strongly urge the patient to have immunotherapy. After all, they have two young children. I appreciate even here we are, day 3, deep in the afternoon, and many of you are responding. Thank you. Again, that really helps me tailor the explanations. And here, I'm very glad to see like literally 100%. I think as you are choosing, palliative care is the appropriate answer here. So I won't kind of walk through the other explanations. You are nailing this. What I'm going to call out here is what is the ethical principle that guides this decision? Because it sounds like we all were very confident and comfortable. And really here, I think the one that best guides it is going to be respect for our patient's autonomy and their preferences. We have a patient who presumably is a very well-informed adult who is expressing their clear preferences for care. And while that might not always align with our personal beliefs or what we think is the most appropriate medical treatment, they are making a decision that's consistent with their own beliefs. And again, it's a very important aspect of healthcare in the United States to really emphasize patient autonomy. So when we think about patient preferences, again, the principle here is respect for autonomy, and there's a very marked emphasis. And so we're focused on patient choice rather than other wishes. And I mentioned before, I'm in a practice where I work with a lot of geriatrics and complex medical care. And often, I think 65 to 70% of my patients have dementia. And often family wishes and family have a very prominent involvement. And one of the points that I really emphasize is that the role for decision makers is really to carry out the patient's wish as best as they understand it and know it. And in terms of legal status, we are in very firm ground here. This right has been held up repeatedly by the US Supreme Court. I will say, and one of the things we'll touch on in a later case, pediatrics and children's cases are more complex. Generally, parents have the power to make decisions on behalf of their children when it comes to medical care. Teenagers, particularly with certain contextual features, it can get a little bit less clear with like the minor doctor, which we'll talk about in a little bit with another case. That said, it is very important to communicate with families. And I suspect many of us have had cases where often disagreements with family that weren't ideally handled probably led to making the case significantly more challenging and upsetting than it otherwise would have been. So really good communication, yeah, it goes a long way. So for here, just as you all selected, I think really offering palliative care to respect their wishes makes the most sense. And just as an aside, I think hopefully everybody knows incompetency or competency rather is a legal distinction and a legal judgment. It is not one that physicians in our state can make. We can evaluate capacity, but not competency. That is something for a judge to do. All right, case number 2. So now we have a 21-year-old college student who's brought in by their roommate to the emergency room for acute symptoms of headache and stiff neck for 18 hours. So something similar to one of the cases our infectious disease colleagues brought up. Their past medical history is unremarkable, and the exam, they are somnolent but arousable. They are febrile, they are tachycardic, they have very noted nuchal rigidity. And for labs, they have a white cell count of 24,000. So in the emergency room, they do obtain consent for a lumbar puncture and order a stat dose of IV antibiotics. The patient hears this order and becomes quite agitated, refusing antibiotics. The physician very dutifully, carefully explains the high risk of death and disability from meningitis without antibiotics. The patient, though, continues to refuse, but is becoming increasingly somnolent and altered. So here we have a patient expressing wishes. What is the most appropriate next course of care? Is it A, treat with IV fluids only, as antibiotic therapy does carry significant risk and should not be given without patient consent? Is it B, since the patient has a life-threatening condition, he should be treated against his will? Is it C, obtain a court order urgently and withhold treatment until it can be reviewed by a judge? Or D, obtain consent from the patient's roommate and proceed with antibiotic therapy? All right, let me get one more response. Thank you. Excellent. Okay. So I am going to share the poll. So the majority here are choosing, since the patient has a life-threatening condition, he should be treated against his will. I think we could even add a caveat there, and they are altered and may not have the capacity to refuse. I do think B is the strongest answer choice here. Um, One of the things I want to call out about answer choice C, which several of you picked, I mean, in many ways, it would be nice to have the backing of the legal system. For those who have been involved in voluntary holds or other situations involving the court, courts do not move quickly. And as we know, meningitis does. So while that would be, I guess, in an ideal world, something that potentially could happen, it is not going to happen in the time frame that we need it in any way, shape, or form. So in this case, which seems to conflict directly with the prior case, and we're coming up with a different answer, is what is the ethical principle that guides our decision here? And here we're really balancing with the principle of beneficence, which is to say we're trying to take care of our patients and provide appropriate care, and really giving them life-saving treatment. And this is where we kind of come up to the limit, the contrast in patient preference and how this differs from the first case. So we have an obligation to assist others in furthering what we believe their interest to be. Again, this is to help, and of course, the other caveat to that is at least do no harm. But this can be challenging, right? It can be enigmatic when there's a refusal of therapy for life-threatening conditions. So example here, a healthy young patient who's refusing antibiotics for meningitis. And in this case, while antibiotics do carry some risk, really ultimately the risk is pretty low, particularly relative to the meningitis, and the benefit is quite great, right? We can prevent death and disability. The provider has an ethical obligation, particularly when the patient's capacity to make that decision, we believe, may be altered. Um, we really want to explore why they are refusing it. And if they can express something that is consistent with their value system and it is consistent and they are able to express it clearly, well, that's a different story than someone who's altered and is unable to explain their reasoning. So in this case, the beneficence is going to outweigh patient autonomy, particularly when the patient is unable to kind of walk us through that autonomy, and we have reason to believe it may be being compromised by their ongoing medical issue. And I think we could talk about this at length, and there are certainly more challenging cases we could come up with, but it looks like most of us were kind of on board with why this makes the most sense. So for this case, I think really the most consistent, most appropriate answer, and also the answer for your boards, life-threatening condition, altered patient, beneficence outweighs, we should treat against their currently expressed wishes. And I will just say as a pause, please go ahead and feel free to put questions into the Q&A, and I will tackle them as we are able to as we go. All right, so some other contextual features, and I am sorry, I think all right, sorry, I clicked something else on my screen. So other contextual features, when we're thinking about religious preferences and how that weighs in when a patient is expressing their wishes. Basically, the courts have upheld that adults can refuse care on a religious basis. That is, their rationale can be based on their faith. Where that becomes more challenging is adults can't generally do that, withhold life-saving care for their children on a religious basis. Now, there are a lot of nuances to that, and we've all probably read cases recently in the news where it certainly seemed like parents made decisions that weren't consistent based on religious views that led to death and disability. One of the other aspects to this is women cannot be forced to have a cesarean section or internal fetal monitoring against their wishes. So these are just kind of extra contextual features when you're trying to balance someone's strongly held religious beliefs. So that absolutely weighs in and factors in, and we are obligated to follow that when it comes to their autonomy, but it gets more challenging when involving with children and their healthcare. Now, that said, we are internists, and we probably are not caring for a pediatric population very often. Another aspect where this can become challenging are when there are strong cultural differences. Each of us has our own ethnic backgrounds and our own culture that we grew up in, and there are definitely strong differences, and we will care for a wide range of different peoples in the course of our careers. And in some cultures, different things are more acceptable than maybe the culture that you grew up in. For example, one that we see fairly often is there's definitely cultures where it is more acceptable for grown children to take responsibility for their parent and to make decisions on their behalf. And in fact, I've certainly personally had cases like this where the patient has fully deferred even life determining and life-saving decisions to their children, even when they themselves have the capacity to make it. And I'll say this can be problematic because I've also had this personally in my practice where the adult children who the patient has deferred to has said, please don't tell the patient this bad news. And in US medical, like generally in US society and in our medical culture that probably most of us trained in, it's problematic for us to withhold information, right? There's this expectation and an expectation of transparency. And in fact, I'm going to bring that up in other cases that I'm going to give you in a little bit. And so we're kind of trained, ideally, we're going to have informed consent by discussing it with our patient. And this is an area where it can be very, very challenging and where your communication goes a long way. Now, that said, it is probably unlikely that you'd have more than one or two questions on your board where this would be the focus. So I wouldn't lose a lot of sleep over this. But generally, verbiage where you really clarify with the patient that truly they want to defer to someone else can be very helpful here. Something like, who would you like to make medical decisions if serious problems arise? You could even add, if there was really upsetting news, would this still be something you would prefer for me to give to this, right, your adult child and not tell you, and that you are okay with that? So again, clear communication that you document goes a long way. Which then leads into disclosing information. So these ones get into the ethics of that transparency that I mentioned. So case 4, we have a 56-year-old man with type 2 diabetes who's being hospitalized for treatment of cellulitis. He's given 100 units of long-acting insulin instead of the 10 units that he usually takes. The mistake, fortunately, is discovered very shortly after it is made, and the patient is placed on a D10 IV drip to help protect them from the effects of that high insulin dose. So this leads to, what do you disclose and what should you tell your patient? Answer choice A, say nothing. Disclose this error only if the patient asks about it. B, you are at risk for low blood sugar, so you will be receiving a drip with glucose in it. C, we are concerned that you could have had too much insulin and may develop low blood sugar, so we will be monitoring you closely with the glucose drip. And D, a dosage error was made and you received 10 times the insulin dose ordered. You are receiving a glucose drip to help prevent low blood sugar. All right, wonderful. I am very, very glad to see, particularly that heavy emphasis on the majority are choosing D, which is being very transparent. Notice that really B and C are involving a lot of passive language, and while C does elaborate more, it doesn't actually acknowledge that a mistake was made, which is why D is the best answer choice here, right? We are being transparent. We are explaining a dosage mistake was made. This is what happened, and we're working to protect you and to rectify the mistake. So when disclosure of medical errors, the things that we need to think about both in our own practice and for the boards. If there's to be a one phrase, a one-liner here, it's tell your patient, right? Disclose, tell your patient. A medical error should be disclosed if a patient suspects or knows that an error has been made, or even if there's the potential of an error that could affect your patient, their well-being, or anything else about their health and the care that you're providing. And an important piece, the disclosure is not dependent on the likelihood that the error would otherwise be recognized. So even if it's something that is so small that it will make no difference, the expectation is still to disclose it. And I think a key element here, which is probably something that if you feel like an internal oof when you say that, or you're kind of owning up to an error, it doesn't imply negligence or unethical behavior. However, failure to disclose them absolutely can. So we are ethically obligated and legally obligated to be forthcoming about healthcare injuries and errors. And one thing we know, and there's a lot of evidence to support this, patients want us to acknowledge even minor errors. And in fact, in many ways, it can actually help build rapport and trust because often when patients are involved in litigation against clinicians, one of the key driving explanations is that they want to find out what happened. They wish that there was transparency. So there is a lot of, not only is it the ethically right thing to do, but the legally correct thing to do to share what happened. And in fact, selfishly, it also reduces probably your risk of litigation. So that said, we also have data to show that we as a profession aren't great at disclosing errors, even though indeed there's compelling reasons to do so. And another part, which disclosing the error leads nicely to, is explain how you're correcting it, like what you're doing, and how you're going to keep your patient safe. Now, that said, this is the other little legal caveat here. Um, Very likely you will have risk management unless you're in a very small clinic. But most bigger like hospitals and medical clinics are going to have a risk management team, and it's appropriate to notify them as well. They can be helpful in making sure that restitution and costs are addressed, and they also can help you with language and verbiage, which can be helpful. And a key thing when you are explaining to your patients, you do not need to offer financial restitution, and often patients are not looking for that. I think that's also a key thing to know. So getting back to this question here, I think the best answer is a dosage error was made and you received 10 times the insulin dose ordered. And then go on to explain how you're going to correct it. Okay, case number 5. And this is going to involve our kind of single exposure to somewhat pediatric medicine. We have a 16-year-old gifted athlete who comes to urgent care for a physical exam that's required by their school to play soccer. The girl's mother, who's their legal guardian, is at work and not available. Um, the patient has no contact with her father, and the chart reveals numerous missed appointments. It has been more than 10 years since she has had a tetanus shot. The patient is anxious to have the tetanus booster, so her coach will let her practice, of course. And she shows adequate understanding of the potential complications of the vaccine, and she also asks at the same time about contraception. As far as your exam, she's healthy, completely reassuring physical, and normal urine analysis. So there are question, perfect. The state has a mature minor statute, and laws about care for emancipated minors that do not include immunizations in urgent care. What should be given in the care of this patient? So answer choice A, give information about contraception and give the tetanus booster. B, defer both tetanus and contraception discussion until the mother is available. C, defer booster but provide information about contraception. And D, give the tetanus booster and defer contraception discussion until the mother is available. All right. I'm going to close the poll and share, and I am very impressed. So the majority are going with defer booster, but provide information about contraception. And then a fair number going for give information about contraception and give the tetanus booster. And so this is challenging, and I think this is worth us knowing, even though we are internists and not pediatricians, because again, occasionally some of us will see 16, 17, and 18-year-olds in kind of the course of normal practice. So when it comes to the care of minors, minors can they can have their status legally changed to act on their own behalf. And I think this is very, very rarely done, and there are quite a few steps involved. And laws have also been created for exceptions to the requirement for a guardian consent for care. And these are kind of really key carve-outs that it's worth you being familiar with. Probably unlikely to be tested on your boards, but good for you just to know in the course of your day-to-day practice. So kind of the exceptions that don't need guardian consent are emergency or urgent prescriptions like life-saving care, STI treatment, pregnancy and contraception. Now, the age of consent for minors for receiving their care and making those decisions varies state by state, and it is worth you knowing what your state, kind of how that, what the legal status is in your state. Um, and then immunizations, curiously, are not usually included in most statutes on exceptions to consent. So notice again, I mentioned urgent emergent treatments like life-saving treatments, STIs, pregnancy, contraception. I did not say vaccinations there. Now, the mature minor treatment statute, it's up here, I'm not going to read it through to you, but basically, if a minor can demonstrate they have sufficient cognitive capacity to understand and they're acting in ways that suggest a fair degree of independence, that's where this statute can trigger. And this is where, again, you could have those exceptions. But vaccinations of minors is kind of a specific carve out in most states and requires consent of their guardians. What I've also included is a link to the Washington State, where there's a really nice one-pager that the University of Washington School of Medicine has put together, where it walks through like each common clinical scenario and where a minor could receive treatment without their guardian's consent. It's a really handy flyer to have, or at least to know that you can pull up should something come into clinic. So in this case, the most appropriate answer is to defer the booster because that is a vaccination and we need the guardian's consent. However, contraception we can discuss. So the most appropriate answer here would be answer choice C. All right, we are going to keep moving. We're going to go to question 6. So now we have a 49-year-old who required 2 tooth extractions. Thankfully, this was not done by us. This was done by a dentist. He was given oxycodone for 5 days post-procedure. He calls you, the PCP, on Friday asking for an additional 5 course due to persistent pain. He had 2 teeth extracted. He denies any sight bleeding, swelling, or drainage, so nothing that sounds like an infection. Past medical history is notable for prior venous thromboembolism, and medications include apixaban. And of course, this is a Friday afternoon and the dental office is closed. So what is the most appropriate acute analgesic plan for this patient? Is it A, prescribed duloxetine, B, ibuprofen, C, tramadol, D, ketorolac, or E, acetaminophen? All right, can we get 2 more answers? Awesome. Okay, great. So let me share. So we have a couple different choices. We have ibuprofen, tramadol, and then acetaminophen is the majority. And this is a challenging situation that I would say probably comes up at least 2 Fridays a month in my clinic, maybe three. So this definitely, like, this will be a common occurrence. It just happens on Friday afternoons. So I think the best answer choice here is the one that the majority picked, which is acetaminophen. Recognizing that is probably the mildest analgesic here, other than like duloxetine. And as far as why not ibuprofen and tramadol, well, ibuprofen, there is a risk of bleeding with apixaban, and as we all know, like a short course of ibuprofen or an NSAID, probably okay in the setting of anticoagulation, but we want to be cautious. And he has fresh right wounds in his mouth. Then as far as tramadol, tramadol is an opiate, which gets to the kind of the core issue here, which when patients ask, like, why not just a few more days? And it is very easy to fall into this. Like, what's a few more days? Get them relief. It's a Friday afternoon. Everybody wants to go home. Well, so this is rather staggering, and I find jaw-dropping numbers. So CDC data of patients who are opiate naive who are given a 10-day course of oxycodone for a dental procedure. 1 year later, 20% of them remained on oxycodone. 3 years later, 15% remained on oxycodone. That's the kind of thing that really, I mean, if we were to say in a nutshell, why are we currently in this opiate epidemic? Like, this is a huge part of it. So what have been guidelines for a while now is short-acting opiates, right? You want a really short duration, and extending it, you need to be doing a thorough assessment to see if that's appropriate. So when the patient calls in on Friday afternoon, you are really putting them at significant risk by refilling it. You are increasing their chance of them becoming dependent on opiates. And as we know, that is a very bad thing for their long-term health. So the ethics of pain management. Um, you should anticipate, like, this is very fair game for the boards. Generally, the right answer is going to be highly judicious use of opioids. Maybe the exception would be end-of-life care, like hospice care and metastatic cancer, and that's kind of it. Rarely is it beneficial long-term in non-cancer care, chronic pain, or in acute care. It's almost never appropriate. It gets challenging, and I don't think you're unlikely to see this on the boards, but in your own practice, it's very likely to happen when you have legacy patients, those who've been on opiates for a long time. And then really what we're managing is a combination of their chronic pain plus their opiate dependency. And that is a topic for another day, and that's a course in and of itself. And really, when prescribing opiates, particularly perioperatively, it should be the minimal number of days to appropriately cover their pain and to get them off of it as soon as possible. So hopefully you all know Washington State has a database where all pharmacies are required to report into it to track opiate prescriptions. And that is a very helpful tool because when you are prescribing opiates, you have to document that not only do you have informed consent, but particularly if you're prescribing it chronically, that you're doing appropriate urine drug screening and that you've checked the state database to look for signs of other prescriptions. And again, shortest duration possible, avoid renewals. And what that leads to for analgesia, of course, is to prioritize those non-opiate options, which again, you were looking at ibuprofen and acetaminophen, which is great, right? Avoid the opiates. And you really want to avoid dual opiate and benzos together. You probably already know, but having both prescriptions on someone's chart that they have available to them increases their risk of death by 10 to 20 fold. Like, it is a staggeringly increased risk of death and things like falls. Very, very dangerous combination. And then the other thing too, hopefully all of you have had practice in your training with buprenorphine. I'll just say very briefly, this is not a talk on buprenorphine, but a much safer opiate and really an excellent choice for those who are dealing with opiate dependency. So in this case, I think the best answer choice, both in your own practice, but also definitely for your internal medicine boards, will be acetaminophen. All right, case number 7. So we're going to change scope a little bit here. So now we have Mrs. C, who is an 84-year-old who resides in a skilled nursing facility. She's admitted for aspiration pneumonia. She is unconscious, quite altered, deteriorating. You get a blood gas, pH of 7.28, PO2 of only 52. The patient started on IV antibiotics and fluids. Her niece, who's the durable power of attorney, literally has the paperwork for healthcare. Sorry, the niece is the durable power of attorney. The patient has never completed a living will or advanced directives or a POLST. The niece comes in, she meets with you, and she states that her aunt has progressive dementia over many years, and the niece would like the IV fluids and antibiotics discontinued and for us to focus on comfort care for her aunt. The patient's daughter is out of state and not available for a joint care conference. So, question 7. Which of the following statements regarding the niece is true? So A, the niece's request to DC IV fluids and antibiotics is within her capacity to act as the patient's durable power of attorney. B, since the patient herself left no advance directive, instructions to DC IV fluids and antibiotics cannot be carried out. C, the daughter of the patient would make decisions as next of kin rather than the niece, despite the niece being named the durable power of attorney for healthcare. And D, the niece's instructions can be carried out, but only if it is determined that she has discussed the issue with her aunt, basically carrying out substituted judgment. All right, let me share the results. And I agree with the majority of you. This is absolutely within the niece's power and, in fact, her obligation to the patient, which is to make decisions on her behalf when her aunt is not able to make those decisions herself. So she is acting well within her appropriate role. Now, it'd be even better, and I appreciate those who chose answer choice D. It would be great if we also know and the niece was confident because she can say, oh, and my aunt talked to me about how she wouldn't want to be kept alive when she had advanced dementia and she'd want to be allowed to pass naturally. Like that would just be even, like that would kind of be the perfect bow on this case, so to speak. But it's not required. And that's the reason why answer choice A is the better answer choice for the boards, because indeed she can carry it out and we don't have to have proof that she's discussed it. But again, it'd be helpful, and presumably there's a reason why the niece is making this request because she has insight and the aunt trusted her in this role. So, durable power for healthcare. Um, so this is law based on state legislature, and it authorizes individuals to appoint another person to act as their agent to make all healthcare decisions if and when they become incapacitated and unable to do it themselves. And that's a key piece of it that I reassure my patients. Like this only triggers if they themselves are not able to act on their own behalf. So it doesn't allow someone to do things against their will to them when it comes to healthcare. Now, the obligations of a DPOA for healthcare are to carry out the wishes of the patient or to act in the patient's best wishes and interests if those wishes are unknown, if the patient's specific wishes are unknown. And this includes the authority to make end-of-life decisions, like kind of the biggest and the most significant decisions we can make. And of key note, this supersedes the wishes of other family members. It sounds like as all of you recognized. The niece was empowered as the DPOA, even though the daughter is next of kin. That does not matter. Now, an interesting little tidbit that Dr. Whiff calls out, the DPOA authority ends with the patient's death. So, like what happens after a patient's death? Well, there's a decision sometimes around autopsies, and that's a decision that would be made by next of kin, by family. So, kind of just a little nuance there. Now, the limits of DPOA authority. In order to be valid, the order, of course, must be made when the patient has capacity and is capable to do so. So the patient themselves has to be able to consent and understand what's going on when they designate a DPOA. And ultimately, as the clinician, you do need to be comfortable that the DPOA is acting in the patient's best interests. And there are certainly situations that have come up in my own practice where there are times when I've wondered. And I will say to the DPOA's credit, every time with further investigation, I felt that the DPOA was absolutely acting in the patient's best interest. I just didn't have all the information at that time. And indeed, ultimately, we have an increasing emphasis on goals of care. And that you can, in fact, when I explain to my patients why it's important to do that green form, that portable orders for life-sustaining treatment, I emphasize it really is for your next of kin or your DPOA because you take a lot of pressure off of their shoulders. They don't have to guess or somehow discern through the nethers what your wishes are. You've literally put them down and they know and they can just carry out your will. It takes such a burden off your loved ones if you've already made it clear what you want in these most serious of situations. Now, another adjacent topic, a living will. If we were in person, I would ask all of you to raise your hands when you had a patient bring up a living will and you looked at it and you found it kind of pointless and useless. So what a living will is, it allows your patients to express their wishes for care when they themselves are incapable of expressing their preferences, and it can give guidance in terminal and irreversible states. Some of the problems that often come up, like it's not always clear, as we know, when a condition is irreversible. Like we've all cared for patients who are uh, um, quite altered and who are on the ventilator, and we're not sure how much neurologically they are still there. And sometimes it takes a long time to find that out. One of the other really limiting factors to living wills is the terms and the vocabulary is often quite vague. Things like forego artificial means and heroic measures. Like, what is a heroic measure? Like, if we're watching a TV show, maybe that's clear, but in our day-to-day practice, right? Like, it's not like these are the heroic procedures. And then language often requires interpretation, whereas the portable orders for life-sustaining treatment, that green form, is really clear and it's very practical. It's kind of focused on the things that we do day to day in our clinics and in our hospitals. So, when it comes to decision making, if someone hasn't designated a DPOA, there is a ranking of priority for next of kin. And for example, in Washington, the order priority starts with a patient's spouse or legal partner, and then it follows by their adult children, and then usually siblings, and then adult parents. So there's kind of an order of priority, and it is really useful for you to know that, particularly if you're in an inpatient setting, whatever state you happen to be practicing in. One of another nice kind of tidbits to know, if there are multiple family members who are reaching out to you asking for input or information on a patient's care, you can actually designate a representative to speak with the rest of them. You are not obligated to call 10 separate family members to give an update. And you get to kind of say, you know what, I'd either like all of you to figure out who you want this one person to be and I'll update them, or you'll say, you know, this person seems to be here the most often. This is the person I'm going to designate. And you know what, others will need to talk with them. So that's something else that's a really helpful thing to know in the hospital. Now, one of the other orders of priority that can supersede all of this. If a patient doesn't have a DPOA or if a court becomes involved, a court can appoint a guardian. And usually there are very stringent requirements for this and involves a patient not having competency. And that person, that guardian, kind of supersedes everybody else in the decision-making hierarchy. All right. Now, and this is probably unlikely to be brought up on the exam, but a good thing to know with decision making is that sometimes a short-term trial of therapy to determine kind of the patient's response and course can be helpful when you have conflicting views, particularly if you don't have a clear decision maker. So a case that I often saw in the hospital is when a parent, when they have multiple adult children, and none of the children have been designated as the decision maker, so all of them are equally the decision maker, and they'll have conflicting views. And I bet, again, if I were to ask for a raise of hands or show of hands, many of you would raise your hand that you've seen that too. So this is a situation where, again, a trial to say, well, you know, it's unclear what direction we'll go here. Why don't we use tincture of time and a trial of therapy to see if this indeed seems to be reversible or to see what their quality of life might be. And kind of a helpful reminder, legally speaking, withdrawing treatment is the same as withholding treatment. Although I think for all of us that feels very different. Like it's one thing to take someone to extubate them as opposed to not intubating them in the first place. So for case 7, we are on firm ground. It really should be honoring the niece's wishes as the DPOA. Okay, we're going to transition now into privacy and confidentiality. So case number 8, you were asked to provide records via fax to an outside hospital emergency room for a 39-year-old patient who presented with fever and dyspnea. He has a mechanical aortic valve and was placed for a bicuspid valve 6 weeks ago. And which of the following should be done to be in compliance with HIPAA rules as you care for this patient? A, the patient's consent is required verbally to fax the records. B, the patient will need to sign a written release for information to be given. C, as the patient is too ill, his wife should sign the release of information request. Or D, you may fax the information without consent for the patient since it is for an urgent medical condition. All right, I know we're going fast. We're getting late in the afternoon. Get a couple more answers. Excellent. I will say this is a personal pet peeve, this clinical situation of mine. So let me end the poll. I'm going to share the results. And I will say the majority of you, you are absolutely right. And this is, again, hopefully a very helpful one for all of you to know that may save you a lot of irritation in the future. You are coordinating a patient's care. Like HIPAA is actually quite clear in this regard. You can fax the information without consent for the patient. And I can't tell you how many times I've been on the phone with the medical records department where the person on the other end of the phone does not know this. So you don't have to get verbal consent. You don't have to get a written release. This is involved for the coordination of care for that patient right now. You can absolutely send it, or if you're requesting it from another institution, they need to send it to you. So I'm not going to go through HIPAA extensively. I think all of us, that would put us all to sleep. But if there are questions on the boards, they'll be pretty straightforward. And the HIPAA privacy rule that use and disclosure of a patient's medical information is allowed for treatment purposes. That is explicit. We do not need consent when reviewing a patient's case or records with consultants, and consent is not needed to send and receive, like to fax outside medical records, as long as it is involved for the medical care of the patient. That goes without saying. There are special rules for behavioral health and psychotherapy. So that's kind of a little different nuance, which is unlikely to be brought up on your boards. And one of the things here is that you get to use your judgment about discussing a patient's status with family members if a patient is unable to give consent. So that patient with meningitis and their parents rush in from earlier, like again, you can use your judgment here. If the patient hasn't clearly expressed when they had capacity that they did not want their family members to know, then again, you are able to determine. So, and I've included a link here if you want the proof of it. But indeed, we absolutely can share that information in regards to their medical care. All right. Let's go ahead. One of the other caveats that you also are allowed to break patient confidentiality is when you have information that you believe involves that the patient is at harm for themselves or that someone else is at risk for harm due to information your patient has disclosed to you. Again, very firm ground that you can do that. So for case 8, you absolutely can fax that information without consent because, again, it's for coordinating a medical care, like that patient has an issue that is happening right now. Okay, next question. Question 9. Your hospital team is caring for a patient with MSSA sepsis. They have a new neurologic findings and they have a rash. The skin findings include suspected Osler's nodes and Janeway lesions. That's kind of neat, right? We learned about those in medical school. So your senior resident takes out their phone to take foot photos to review the case during morning report. So which applies to being clients with the HIPAA security rule? So A, the patient should be verbally asked if he consents to the photo via cell phone for teaching purposes. B, use of the cell phone for photos requires patient-informed consent. Note use of personal phone as well as noting security measures. C, HIPAA does not apply since the images do not include identifiable patient features. Or D, a personal cell phone can never be used when requesting photographs of patient findings. Ooh, I'm really glad that we have this question. I'm glad that Dr. Whiff included this because it looks like this will be another very helpful one for all of us to review and to know. So let me share the poll. We kind of had everything selected. Yeah, which I'm guessing because we've probably in our own practices seen maybe all of these different things done. Um, so the best answer choice here is actually the use of a cell phone really requires patient-informed consent, even though there is no identifying information. And we do have to know that we're using a personal phone and indeed what security measures there are to keep that data safe and confidential. So it is answer choice B. That is what is necessary to be in compliance, like to be doing this appropriately, both ethically and legally. Um, I will just note, because many of us chose answer choice C, HIPAA still does apply, even though there isn't identifiable features. And it's not sufficient to ask for verbal consent. All right. Question 10. We have a 33-year-old man who presents to the ED with urethritis, and discharge shows intracellular gram-negative diplococci. When told the diagnosis of gonococcal urethritis, he says, "Please don't let my wife know. I promise this will never happen again." What should you do? Answer choice A, treat the patient and respect their wish for confidentiality. B, treat the patient and instruct him to contact his wife. C, tell the patient that he and his wife must be treated, then she will be notified about the exposure. And D, treat the patient and contact the patient's wife to inform her of her risk and need for treatment. Yeah, this one, and I fortunately, I think only had this happen to me twice in my career. Very awkward. All right, let me share the results. Again, we have several different answer choices that were selected. Um, and the majority were going, tell the patient that he and his wife must be treated and that she will be notified about the exposure. Yeah, so this one here, and I see the answer choices for B and D. So let's walk through this. So confidentiality, um, the confidentiality of the doctor-patient relationship is not absolute. In fact, we already noted that in cases where someone, we either believe they themselves are at risk for harm or someone else other than your patient is at risk because of something your patient has told me or told you, then you can absolutely violate the confidentiality. A patient who asks that medical information be withheld should be honored unless, again, it's in the common good or others are at risk. And if the patient specifically conveys to his or her doctor plans to harm a named individual, we need to report this. We need to convey this to the appropriate authorities. Those are our legal and ethical obligation. Now, when it comes to reportable illnesses, reportable diseases, things like STIs, um, uh, there are pretty clear expectations that there are a number of reportable conditions. In fact, the entire list is like 2 pages. Reportable infectious conditions. These include things like chancroid, chlamydia, gonorrhea, herpes simplex, non-gonococcal urethritis, acute PID, syphilis, of course, HIV. So each state has individual rules, and you really want to know if you're practicing in a different state what those rules are. Like in Washington, now the expectation is that for primary care clinicians are responsible for the notification both of the state and of partners. Um, and sometimes HIV has slightly different rules, but indeed it is a mandatory reporting condition. And often states will have a mechanism through public health departments to notify partners. Another one where this often comes up are cases of tuberculosis. So it is worth you perusing if you're practicing in a different state, what are the reportable conditions and what your obligation as a clinician is. So in this case, what you should do is you absolutely should tell the patient that both of them need to be treated and that she will be notified about the exposure. And again, dependent on the state that you are, the state that you're practicing in, what you need to do next beyond that might vary. But the very least will involve notifying the appropriate public health department. All right, we are going to keep moving. I know I'm going quite fast. We have a couple more cases to get through. So, case 11. You are the primary care physician for a 44-year-old man with polyposis of the colon who's recently had a colectomy. He has 2 children, ages 18 and 22, from a previous marriage. Family history notable for a motor vehicle accident in the father and a mother who's alive and well, doesn't have any siblings. Now, when you discuss the genetics of the polyposis, the patient says that he does not want to notify his children. So, in this uncomfortable situation, the patient with this polyposis of the colon, which, as we know, is a genetic condition, what should your response be? A, urge the patient to allow you to contact the children. B, contact the patient's wife. C, tell the patient that you're legally required to notify the children due to a high risk of cancer. And D, do nothing since transmission is autosomal recessive and the risk is low. All right. This is very impressive. Okay, so this is almost a 50-50 divide. And again, hopefully this will be a really useful question for you just to know, not only for boards, but really also for your practice. So I know we just talked about how if you are aware of something that could compromise someone else's like immediate health and safety, right, we have an obligation to act and we can break confidentiality in those situations. Genetics are different, and we don't currently have clear laws about notification of those at risk for an inherited disease. Just as an aside, just a reminder, familial polyposis is, of course, not recessive, it is autosomal dominant. So we can try to urge the patient to do what we think is in the best interest of the health of their children, i.e., to notify them so that they can get screened. However, we don't have a legal obligation or permission to do so. And while there have been cases for it, we haven't had any ruling that has allowed a clear determination of where kind of what is the appropriate action to take. So in this case, as uncomfortable as it may be, I think the thing that probably would feel best to us in terms of both balancing patient's autonomy and beneficence and thinking about potential harm to others would be to urge the patient to allow you to contact the children or for themselves to do so, but we are not legally obligated, nor are we able to do so against their wishes. So again, hopefully this is helpful to you. Answer choice A is the best answer here, even though I think probably many of us would hope that what happens is C, or at least that the children get notified. Okay, we're going to continue this theme of uncomfortable situations. So question 12, your surgical colleague just performed a cholecystectomy on your patient. Hooray! As you are visiting the patient post-op, you talk with the surgeon and realize the surgeon has signs of alcohol withdrawal or intoxication. And you're such a good clinician, you also suspect that they may have Wernicke's encephalopathy. What should you do? A, ignore. After all, Charlie will be Charlie. B, talk with Charlie's wife. C, bring up this to the hospital board urgently. Or D, talk directly with your colleague and urge them to seek counseling and treatment as soon as possible. All right, I am going to close the poll here. And I will say I'm glad. I agree with the majority here. And our best answer is going to be to bring it up with the hospital board urgently. We have a reasonable suspicion that our colleague is practicing in an unsafe manner and putting patient lives at risk. And this is very clear, both legally and ethically. We have an obligation to act to protect our patients. Now, we don't have omniscience. We don't know for sure, but we have a very reasonable suspicion. And I will say for those who picked answer choice D, you're probably thinking this is going to cause some awkwardness between you and Charlie. And I think you're absolutely right. But our obligation as clinicians and physicians is to act in the best interest of our patients. So here it's absolutely that we notify because Charlie should not be operating on patients in this state. But yes, this will lead to awkwardness. All right, we are nearing the end. So in general, if an ethical dilemma can't be resolved, when in doubt, do not withhold care in an urgent situation. So if you're unsure in regards to, say, mechanical ventilation, proceed with it. Like if you don't have clear guidance from the patient or a DPOA who is expressing a clear preference, a clear decision. And just as a reminder, part of the reason for this, courts view the withdrawal and the withholding of care as the same. Again, we might kind of, in the nature of practice, see them as different things because it feels different to withhold care, at least it does to me, than to not initiate in the first place. But legally, there's really not a distinction. If you have a challenging situation and you have kind of the benefit of time, an ethics consult can be really helpful. It is unlikely that that's going to be the appropriate answer on the test because it's probably not going to be a complex situation where there's a lot of time. It'll be a more straightforward situation, very likely, for the ethics questions. Um, but in your own practice, and if it's a non-urgent situation, an ethics consult can be very, very helpful. Other things to consider, which I will say I have done very recently, is obtain advice from the hospital attorney or risk management. Often they can be very good, not, I mean, also obviously in the legal sense, but also just in terms of wording and ways to approach challenging situations. And then a last resort, which I already mentioned, is not a fast option, is a court decision. And probably all of us, if you haven't had it yet, probably at some point in your career you will, where there's a disagreement between family members where they are each of equal position in the decision-making hierarchy, and they just can't resolve it. And I will say these are heartbreaking situations and the ones that I've been in. And when we have to get the court involved, there are always going to be hard feelings. Um, so I'll leave it there other than to say the legal system is slow, and it is very unlikely that that is going to be the answer on the test. So I want to thank you so much for attending our course. We have one final talk. If you have any questions, please feel free to reach out to me. Again, I'm happy to field questions for the geriatrics talk, as well as, sorry, I'm blanking on the other talk, the diabetes talk that I did earlier this week. And I think this is a very, very cute comic. I'm the doctor who brings the cards. I am a cardiologist. Ha, ha, ha. All right. So with that, I will pause. We do have a little bit of time for questions, and it is okay if we do not have questions because our next speaker, the phenomenal Dr. Nanette Robinson, is here, and we may be able to have her start a little bit early if there are not other questions.